Hello, my name is Jocelyn Villarreal, and today we will be doing a head-to-toe examination as an advanced health assessment student. The general appearance and vital signs of the patient are as follows. He is a 24-year-old Hispanic male presenting to the clinic for a wellness checkup. He appears to be well-nourished, appropriately dressed for the weather, and is well-groomed. He is alert and oriented to time, place, and person, and appears to be without signs and symptoms of acute distress. He denies any food, medication, or environmental allergies. Vital signs have been collected and are as follows. Height 5 feet 6 inches. Weight 190 pounds, which means our BMI is of 30.7. Blood pressure 112/72. Heart rate 79. Respiratory rate 19. Temperature 98.6. And oxygen saturation at 100% on room air. Having established that our patient is without any acute distress, we can proceed with his head-to-toe examination. But first and foremost, I would like to obtain his consent to get a video recording of today's exam.
Yes.
Perfect. So let's start off with our skin assessment. Okay. So we're going to start off with our assessment of the skin, and this is also an assessment that should be conducted continuously throughout our head-to-toe assessment. So what I'm first looking at here is the patient's facial asymmetry or symmetry. I'm noting any swelling or any drooping of the face. And in the head, I'm also checking for any central cyanosis, which could be indicative of poor perfusion. I'm looking at the color, which is even throughout, and I'm also going to be checking for excess skin moisture or dryness. And I can feel that the skin is warm to the touch. I don't notice any lesions or any abnormal abrasions or masses. I'm also going to be taking a look at the patient's fingernails and assessing their general shape and the color of the fingernails. And we will be checking for capillary refill during our peripheral vascular system examination. So I'm going to have you place your fingers like this, and here I'm looking at the angle of the nail placement, and it appears to be about 160 degrees, which is a normal finding. We would see excess in clubbing of the nail in patients with chronic respiratory illnesses. The nails are also pink without any bluish tint or discoloration. I'm also taking a note of the hair here, and the hair appears to be evenly distributed in both the arms and the lower extremities, and it appears to be coarse in texture. Moving down to the lower extremities, again, I'm looking for any abnormalities in the skin. Also checking the temperature of the lower extremities, and I can see that it is warm throughout. So another part of our skin assessment is assessing for melanomas. If there is any characteristics such as asymmetry in a new nevi or border irregularities, color variations, or a diameter greater than 6 millimeters, and lastly elevation of a nevi or a new nevi, then we could refer the patient out to a dermatologist, and we can also show him how to assess for these new moles or nevi that may appear. So now proceeding to our assessment of the head. Again, here I am looking at the position of the head compared to the rest of the body, and I can see that the head is round, symmetric, normocephalic. Facial symmetry is also even here. And again, I'm going to be wanting to assess the hair. So moving to the scalp, I'll be palpating the scalp, and here I'm feeling for any depressions, which could be indicative of any previous head trauma or head surgery. Any tenderness there? No. Very good. So I'm also going to be wanting to check the scalp And the scalp, I'm noting the color, and it is white. I'm checking for any infestations or any lesions or masses again in the scalp. And then again, I'm going to be assessing the hair, taking a note. And the patient does have coarse hair, and it's evenly distributed throughout the scalp. Now inspecting the face, the facial expressions, the eyebrow hair, and the eyelash distribution is symmetric on both the left and the right sides. I'm going to be turning off the lights to do an examination of the pupils. I'm going to be using my pen light to inspect both the eyes and the eye structures. And I'm checking the conjunctiva on both eyes. So I can see that the conjunctiva are pink, the sclera are white bilaterally without any pallor, which could signal dehydration, or any icterus, which could be seen in patients with hepatocellular disease. I can also see that the cornea and lenses are clear, and both eyes appear to be without discharge, ptosis, or lid lag. I'm going to have you look at a distant object across the room. And I can see that the pupils are equal, round, and reactive to light and accommodation. Now I will be doing my ophthalmoscope exam. I am going to start off by visualizing the red light reflex and moving towards it until I can visualize the retinal background. And on the left eye, I can see that the retinal background is clear, even in color, pink-orange, and without any exudates or hemorrhaging. I can also visualize the optic discs, and they have sharp margins. So for example, the optic discs, we would visualize any cupping or blurring of these edges in papilledema, which could be seen in patients with glaucoma. I'm going to repeat my ophthalmoscope exam on the left eye. But now switching hands. The left eye also appears, the retinal background appears to be clear, pink in color, without any hemorrhages or exudates, and the optic discs have sharp margins. Now proceeding to our ear examination. Having placed a clean tip on my otoscope here, I'm going to be starting off by examining the structures of the right ear. I can see that there's no masses or deformities on the ear, any pain or tenderness, and there's no pain on palpation in the tragus or anywhere around the ear. Now visualizing my ear canal. I'm going to be pulling the patient's ear up and back. And I can visualize that the tympanic membranes are pearly gray in color with the cone of light on the right ear at 5 o'clock. I'm going to do the same, but now on my left ear. And again, I'm going to assess the ear itself and palpate for any pain, tenderness, or masses. Any tenderness around the ear? Very good. Now I'm going to proceed by checking my ear canal. Again, pulling back and out, up and out. My tympanic membrane on the left ear is also pearly gray in color, translucent, also without any bulging or retraction, which could be seen with ear infections. And my cone of light on my left ear is at 7 o'clock. Now moving on to our hearing tests, our Weber and Rhine Our Weber test is going to be used to assess for lateralization. I will be striking the tuning fork and placing it in the scalp, and let me know if the sound lateralizes louder to one ear or the other, or if the sound is equal in both.
Equal.
In both? Very good. And now I'm going to do the Rhine test by placing the tuning fork behind the ear or on the mastoid process. And for this, I'm going to have you tell me when you can no longer hear the sound, and then I'll move the tuning fork over to the side of your ear.
I don't hear it.
Okay, and then here we can see that air conduction is greater than bone conduction, which is a normal finding. The opposite would be true in conductive hearing loss. And during these tests, we're also taking a look of the time. If the patient can hear the tuning fork on the side of the ear longer than he can when it's behind the ear, that's when we're able to tell that air conduction is greater than bone conduction. I'm going to repeat the exam, but now on the left.
I don't hear it.
Very good. And the same is true for the left ear. We can see that air conduction is greater than bone conduction. So that concludes our examination for the ears. Now I'm going to be moving down to the nose, and here I'm inspecting the anterior and interior surfaces of the nose. The nose appears to be symmetric without any abnormalities or deformities. Now changing the tip of my otoscope, I'll be inspecting the nasal passages. Just tilt your head up a bit. The nasal turbinates appear patent without any swelling, redness, or drainage in either nair, and the septum appears to be midline. Now I will be palpating for sinus tenderness, starting with our frontal. Any pain, tenderness here?
No.
And then our maxillary sinuses by pushing up on the sinus. Pain, tenderness?
No.
Very good. So any pain or tenderness in these frontal or maxillary sinuses would be indicative of acute sinusitis. Now inspecting the mouth again. Here I'm looking for the color, the moisture, the placement of the lips. The lips appear to be symmetric on both sides without any drooping, which would be common in patients who've just had a stroke. The lips are also moist, pink, without any cracking, masses, or lesions. So here, if our patient were to report a sore on the lip or mouth that is unhealed for a certain period of time, this could be indicative of a mouth cancer. Now inspecting the oral mucosa, I'm going to have you open up your mouth. And the oral mucosa is moist and pink. I can see that all dentition are intact. I'm also looking for the integrity of the gums or the gum line. I'm looking at my posterior pharynx, which is non-erythematous. I'm looking at my tonsils, and they are 1+ in size. And very importantly, I'm looking at the tongue, and I'm looking at the floor of the mouth, which is especially important because any sores, lesions, ulcerations in this area could be signaling leukoplakia or other types of oral cancers. But I can see that the tongue is moist and pink without any of the ulceration. Now we can move on to our examination of the cranial nerves as part of a neurological examination. We've already established the patency of the nares with our nostril examination. So for cranial nerve number 1, our olfactory nerve, I am going to ask the patient to sniff 2 scents and go ahead and close your eyes and occlude 1 nostril and let me know if you can identify the scent.
Yes.
What is it?
Cinnamon.
Very good. And now I'm going to have you occlude your opposite nostril, and then can you identify this scent?
Yes.
What is it?
Vanilla.
Very good. So we can see that our cranial nerve number 1 is intact, and we can see that the patient is able to distinguish at least 2 different types of smells. Now doing cranial nerve number 2, this is our optic nerve and we're checking for visual acuity, and I will be using the Rosenbaum chart for this. You can utilize your glasses and then read the line with the smallest characters that you can see with one eye closed.
LTFPH.
Very good. Now do close your other eye.
LTFPH.
So we can see that the patient has 20/20 best corrected vision. And a part of this testing for the cranial nerves, we will be doing our visual field examination here. So let me know when you're able to identify my fingers at your sides. Ready?
Mm-hmm. Yeah. Yeah.
Okay, very good. So we can see that the visual field is full by confrontation. We would also be assessing our optic fundi to check for our cranial nerve 2 function, but we've done this earlier with our examination of the eye. As for our cranial nerves number 2 and 3, our optic and oculomotor, we've done our pupillary exam earlier with our eye examination as well. We can move on to cranial nerves number 3, 4, and 6, which can test for our extraocular movements. So with your head still, I'm going to have you follow or trace my finger with just your eyesight. So I can see that the extraocular muscles are intact without any nystagmus. Now, moving on to cranial nerve number 5, there are several portions to this, including our motor, sensory, and our corneal reflex. So to test for our motor function of cranial nerve number 5, I'm going to palpate the temporal and masseter muscles while you clench your teeth. Very good. Excellent. So we can see that the motor function is intact. Now checking for the sensory portion of cranial nerve number 5, and then identify whether the sensation felt is a sharp, which would feel like this, or soft or dull sensation like this. Ready?
Yes. Soft. Soft. Sharp. Sharp. Soft. Sharp.
Very good. So we can see that the sensory portion of cranial nerve number 5 is intact. We can also assess our facial tone here, which is symmetric without any tics or tremor. Now checking the corneal reflex, I will be checking for the upward movement of the eye after stroking the eye with the cotton wisp. And to our left eye as well. Very good. So we can see that our corneal reflex is intact, and that would conclude our cranial nerve number 5. Now checking cranial nerve number 7, I'm going to have you do a series of facial movements to assess the integrity of this nerve, starting off by raising your eyebrows, frowning, close your eyes, and shut them tightly. And here I shouldn't be able to open them. Very good. Now show your teeth, smile, and then puff your cheeks. Very good. So here I'm observing for, again, any unusual facial movements and asymmetry which could signal muscle weakness. Now doing cranial nerve number 8, this is to test for hearing or our acoustic nerve. I'm going to have you occlude 1 ear and repeat the whispered number back to me.
7.
Excellent.
13.
Excellent. So we can see that cranial nerve number 8 is intact. Now doing cranial nerves number 9 and 10 are glossopharyngeal and our vagus nerve. So here is especially important to do throughout the entire examination. You should be listening to any speech sounds or any hoarseness or any difficulty swallowing. And then to check for the motor function and integrity of these two, I'm going to have you say ah.
Ah.
And perfect. So there is a symmetrical rise of the palate and the uvula is midline. If we don't see a rise of the palate or if the uvula is deviated to one side or the other, this is indicative of cranial nerve 9 or 10 damage. Now to check for the gag reflex, this still applies to cranial nerve number 10. I will be lightly touching the back of the throat. So I can see that there's upward movement of the palate and the gag reflex is intact here. Now moving on to cranial nerve number 11, our spinal accessory. For this, I'm going to have you put your gown down. Now to assess for cranial nerve number 11, now looking at the back here, we are assessing any kind of tremors, fasciculations, or irregular movement in our trapezius muscle here. And I can see that the patient doesn't show any signs of that. And I'm going to have you shrug your shoulders upward while I apply some pressure. And this is also testing for the strength, which is good strength, 5 out of 5. And then I'm going to ask you to turn your head side to side with some resistance. Very good. And I can see that the cranial nerve number 11 is intact here. Lastly, cranial nerve number 12 is our hypoglossal nerve. Here I'm inspecting the tongue at rest. So go ahead and open your mouth and protrude the tongue. Move your tongue side to side, curled up, then curled down. So lastly, to check for the muscle strength of the tongue, I'm going to have you push against your cheek. Very good. Excellent. So I can see that cranial nerve number 12 is intact. Moving down now to our neck assessment. So here, most importantly, we're checking for our anterior lymph nodes. And I'm also going to want to palpate my post cervical lymph nodes here. And I can feel the anterior cervical lymph nodes are palpable, non-tender. Did you feel any pain there?
No.
Upon palpation, they're soft and mobile to palpation bilaterally in both the left and the right sides of the neck. The estimated size, I would say, is about 8 to 10 millimeters, which is a normal size for lymph nodes in this area. Whereas the posterior cervical lymph nodes were non-palpable, which again is a normal finding. Now I want to check the position of the trachea. So for this, you identify the sternal notch, and you identify your hyoid and cricoid cartilage. And here we can feel that the trachea is positioned midline. Any deviation in your trachea would be indicative of a respiratory problem, such as a pneumothorax. Next, I'm going to have you take a sip of water, swallow as I observe the movement for the thyroid gland. And then tilt your head a bit back. So hold, swallow, and here I saw the swallowing, but I didn't visualize an enlarged thyroid. I'm going to have you do the same, but I'm going to palpate the thyroid from the back here. Swallow. Very good. So I feel that the thyroid was non-palpable and non-tender. And now we can proceed to our assessment of the back, posterior thorax, and the lungs. Now, standing posteriorly behind the patient, here we're checking for symmetry in our shoulders. So we can see that they're symmetric, and then I can proceed to palpate the spine or the spinous process, checking for the placement, checking for the curvatures of the spine, and it does seem to be midline without any scoliosis or excessive lordosis or kyphosis, which could be seen in older patients. I can also palpate here my upper back muscles and check for any pain or tenderness here. Do you have any pain?
No.
Again, taking a look for any abnormalities in tremors or fasciculations in this area. Then we can do a more in-depth examination of the spine and the range of movement of the spine when we do our lower extremity examination. For now, we can take a look at the posterior portion of the lungs. So I'm going to start off by percussing the lungs in a ladder pattern here, and making note of my sound. So lungs are resonant all throughout the lung fields percussed, which is a normal finding. We can see that there would be some dullness in cases of fluid or consolidation, such as in pneumonia. Now I want to test for my diaphragmatic excursion. This is going to take place during quiet respiration to establish the appropriate or approximate level of the diaphragm here. So now, identifying my scapula here, we're going to be percussing from the level of resonance to the level of dullness. So take a deep breath in and out, and I want you to hold it. Very good. And now I'm going to ask you to take a deep breath in and hold. Very good. Now we can measure our difference. Anywhere from 3 to 5 centimeters is normal. And here we can see that it's about 4 centimeters. Again, making this a normal finding. This test is traditionally used to check for restricted airflow, which could be seen in patients with a pleural effusion. Now I'm going to check for chest excursion. So I'm placing my hands near the approximate level of the diaphragm here. And I'm going to ask you to take a deep breath in and out. And here I'm looking for symmetric movement of both my left and right hand, and I can see that the chest does rise symmetric or bilaterally. We would see asymmetry here when there's limited movement or in unilateral lung diseases such as in bronchial obstructions. For our last part of our back and posterior thorax examination, I will be auscultating the lung posteriorly. So just take normal breaths. Excellent. So breath sounds are full, clear, and equal bilaterally without any adventitious sounds. Now we can proceed with our examination of the upper extremities, and here we're integrating our musculoskeletal and our neural examination as well. At this time, we can do an in-depth examination of the range of movement of our upper extremities. So back to our musculoskeletal examination. Here, we can start off by, again, assessing our shoulders, making sure that they are symmetric, and assessing that there is no atrophy in the muscle, any kind of deformities or winging of the scapula, or any discolorations here, which could be seen in patients who have had a fracture in the upper region. So checking our elbow here, there's no nodules or swelling noted, and we would do all of our assessment again on the other side. Inspecting our wrists and our hands at rest, there's no swelling, no abnormal nodules or deformities, and no radial and ulnar deviation, which again can be a common finding in patients with osteoarthritis. Now we can start palpating our bony landmarks, our muscles, tendons, and ligaments, and we can start off with our sternoclavicular joint by tracing the clavicles and then moving up towards our upper scapula here and the acromion here at the top of the shoulder. From here, I want to palpate down to the coracoid process on both extremities. And now palpating the greater tubercle on the right arm. I'm going to palpate this down towards the bicep tendon and the intertubercular groove. I can do the same on the left. And now with the humerus located posteriorly, we can palpate the bursa and our sits muscles. Let's do the same on the left. So the musculature of the shoulder feels symmetric bilaterally and is non-tender. Now we can proceed by palpating our elbow. So I'm supporting the forearm so that we have our elbow flexed to 70 degrees. I'm palpating the lateral epicondyles here alongside the elbow, and I'm palpating the medial epicondyle here at the top as well. Next, I want to move downwards to palpate the extensor surface of the ulna, which runs down the middle of the elbow, halfway down the arm. And we're trying to identify any nodules or swelling in this region, which could be indicative of olecranon bursitis or arthritis, but I don't feel any of that on the left arm. And then we can do the same on our right hand. Now taking a look at our wrists and our hands, I'm going to be palpating the lateral medial surfaces of the wrist, and then the radial styloid bone and the anatomical snuff box. So here this is a hollow depression at each side of the wrist. Any pain or tenderness in this area?
No.
So here, if the patient were to report pain in this region, this would be suggestive of a scaphoid fracture. I'm also going to be palpating the 8 carpal joints distal to the wrist. And I'm going to be compressing the joints by squeezing the hand from each side. Any pain, tenderness?
No.
And how about on this hand?
No.
So we don't see any pain, tenderness, or swelling or bogginess, which is especially important in osteoarthritis. Now I'm going to be palpating the joints of the fingers. Again, no swelling, bogginess, or bony enlargement of the fingers noted, and again, bony enlargement of these joints is common in osteoarthritis. So now that we are assessing and inspecting our wrists and hands, we can actually test for our range of motion here. Starting off with the wrist, we can start with flexion by pointing your fingers down towards the floor. Excellent. Extend them by pointing them towards the ceiling. And then we can check for ulnar and radial deviation by bringing your fingers to and away from midline. Excellent. So we can see that the patient has full range of motion of the wrists. Now let's check for his range of motion in the thumb. Let's start off with flexion, touching the base of the pinky. Bring it back to extend. Abduct to move the thumb out. Adduct, move the thumb back in. And then opposition is just having the patient touch the thumb to each fingertip. So we can see that there is a full range of motion on the thumb, and now we can check for our range of motion on the rest of our fingers. So I want you to flex the fingers by bringing your fingertips to the palmar crease, and then these joints to the palmar crease as well. Extend them by just spreading them out. Abduct the fingers by continuing to spread them out. Adduct by bringing your fingers back together. Excellent. So range of movement is intact for the wrists and the hands with smooth coordinated movement. Now that we've checked for our range of movement here, we can go back and check for our shoulders and our elbows. Now let's check the range of motion of the shoulders and the elbows. Starting off with our shoulders, I want you to flex by raising your hands forward and above your head. Excellent. Now let's do extension. Bring your hands behind your back. And then adduction, you're going to raise your hands to your shoulders and then bring your palms down. Excellent. To adduct, cross your arms across the body. Now for external rotation, you're going to rotate your arm up with your elbow bent to 90 degrees. And now let's do that on your left. Excellent. Lastly, for internal rotation, I want you to put your hand behind your back to touch the shoulder blade. Very good. Now with your left. So all range of movement is intact, in symmetric and fluid for the shoulders. Let's move on to our elbows. So go ahead and flex and extend the elbow by bending it and then straightening it out. Supination, you're already in this position. You have your palms up, and then to pronate, you turn your palms down. So all four range of movements are expected. Now proceeding with our neurological examination of our upper extremities here, we are also taking a note of the musculature and the symmetry. We're looking for any muscle atrophy and again, any deformities in this area. So let's start off with muscle strength of the hands. I want you to pull as hard as you can. Very good. Now let's test for muscle strength of the biceps. Excellent. And now muscle strength for the triceps. Excellent. So there is good muscle tone and the strength of the hands, the triceps and biceps are 5 out of 5. Now we can proceed to rapid alternating movements. For this, I'm going to have you touch my finger, trace it back to your nose. Excellent. And again, to test for rapid alternating movement of the fingers, I'm going to have you touch each finger with your thumb as fast as you can. Excellent. And then lastly, for this, I'm going to have you turn your palms up and down like that. Excellent. So we can see that finger to nose testing and rapid alternating movements are intact and symmetric bilaterally. Now proceeding to our breast examination for a male. Here we don't note any visible nodules, swellings, lesions, or gynecomastia. The nipples appear symmetric without scaling, excoriation, or deformities, all of which would suggest acquired disease. Additionally, gynecomastia can be seen during puberty, but can also be as a side effect to medications such as phenytoin, H2 blockers, or marijuana. I want to start off by palpating the areola and breast tissue for nodules. The areola and breast tissue are without nodules bilaterally. If the breast appear enlarged here, we would distinguish soft fat from the firm disc that would cause gynecomastia. Next, doing our axillary inspection. Here the axilla appear to be without lesions, rashes, masses, or unusual pigmentation. We would be worried for any lesions in the lymph node area here because they'd be indicative that there is improper drainage of the lymph nodes in this area. So I'm going to start off by palpating the central lymph nodes. You can put your arms down. And I'm going to do the central lymph node of this side. You can put your arm down. I'm going to also be palpating the pectoral lymph node. And then lastly, the lateral nodes, which are high in the axilla along the humerus. And let me do the same on my left side. The pectoral, then the lateral. So the lymph nodes are non-palpable and non-tender in this region, which is a normal finding. Lastly, I'm going to be palpating the infrasupraclavicular lymph nodes here along the underside of the clavicle. These lymph nodes are non-palpable, non-tender, without any masses, so that we can rule out lymphadenopathy. But we would see something like this in breast cancer metastasis. Now moving on to our inspection of the anterior thorax and lungs. The patient is supine and breathing normally. Here I'm looking at the skin condition and inspecting chest for deformities, asymmetry, and most importantly, the respiratory movement. So we can see that the chest is even in color without discoloration or bruising, which again would be indicative of a fracture in this region. And the chest wall rises symmetrically with respiration, and respiration is easy without any retractions, and we can note that there's regular rate and rhythm. I'm going to be palpating for any lesions, tenderness, or abnormalities. Pain or tenderness?
No.
So the anterior thorax is non-tender without any masses, lesions, abnormalities. I'm also going to be percussing over the lung fields. Again, using a ladder pattern for our percussion. So we can see or hear that our lung fields are resonant throughout percussion. Next, we can auscultate our breath sounds. So breath sounds are full, equal, clear bilaterally without any adventitious sounds auscultated. Now moving on to our cardiovascular examination. All right, now moving on to our cardiovascular examination, I have repositioned my patient and elevated him to 30 degrees. And here I'm going to start off by visualizing our JVP with a pen light. So here I'm going to start off by visualizing my JVP using oblique lighting. And I'm going to place a ruler at the level of the sternal angle. Once your JVP is visualized, we can measure it with our ruler, the height. And I see that this is about 1.5 centimeters, which is between normal. Anything greater than 3, our venous, if the height of the venous pressure is 3 centimeters above the sternal angle, this could be indicative that elevated right heart pressure is occurring. At this time, I'm also going to be palpating the carotid pulsations. Again, this is done one at a time. I can feel that the carotids are without thrill with an expected amplitude of 2+. So an increase in this amplitude can also be a result of an increased fluid in the cardiovascular system, such as in heart failure exacerbations. Sticking to our carotid examination with the bell of our stethoscope, we're going to be checking for any bruits. Excellent. So No breaks noted. These can occur with cardiac disease or with peripheral vascular disease. Right now, to assess our apical pulse or our PMI, we're going to want to palpate at the level of our midclavicular line at about the 5th intercostal space. So we can see that our PMI is present in this location with a diameter of 3 centimeters or less. The amplitude is brisk and tapping. So a displacement of the apical pulse is suggestive of a ventricular mass. At this point, we can proceed with our auscultation of the heart, starting off with our aortic pulse, which is on the right 2nd intercostal space, the pulmonic on the left 2nd intercostal, tricuspid at about 3 to 5th intercostal space, and then our mitral, which is at our level of our midclavicular line, 4th to 5th intercostal space. So the heart rate and rhythm are normal. I didn't hear any murmurs, gallops, or rubs. S1 and S2 were heard at normal intensity without splitting. Now moving on to our abdominal assessment, we've repositioned the patient again to flatten the table. So for our inspection of the abdomen, we are looking that it is symmetric bilaterally. The umbilicus is midline. There is no venous patterns, no nodules or hernias, which could be indicative of a malignancy, and venous patterns could be seen in patients with hepatocellular disease. We also don't see any peristalsis and aortic pulsations. Then we can proceed to auscultate our bowel sounds in all 4 quadrants. So bowel sounds are normal active in all 4 quadrants. Now we can percuss our abdomen in 9 different locations. So I can see tympany noted on percussion. Dullness can indicate anything like fluids, organs, or masses. We can also percuss our liver span. Now to percuss the liver, I'm going to start off alongside the umbilicus and percuss up towards a change in sound, which would be indicative of our lower border for our liver. So we're going to take a note of the region. And then we'll percuss downwards to identify the upper border. So the liver span is about 6.5 centimeters. Anything between 6 to 12 centimeters is considered normal. And at this time, we can also percuss the spleen just anterior to the mid-axillary line at about the lowest intercostal level. For this, I'm going to ask you to take a deep breath while percussing. So the spleen remains tympanic with breathing. Any change from tympany to dullness can be seen in an enlarged spleen. So now to do some light palpation, we're gonna palpate lightly about a centimeter in light circular motions. Any pain or tenderness?
No.
So the abdomen feels smooth and soft, and then we can proceed to our deeper palpation in all 4 quadrants. Pain?
No.
So we can see that deep palpation in all four quadrants is without the presence of masses and without any guarding, rigidity, and pain, which could all be seen in cases of peritonitis. So during palpation of the abdomen, we can also palpate the liver by placing a hand beneath the 11th to 12th rib and lifting upwards. But in this case, I'm going to do the hooking technique. So while palpating the liver, I'm going to ask the patient to take in deep breaths. On exhalation, you can do the hooking technique. Take another deep breath. So the liver is palpable and non-tender, and then we can percuss the liver as well. Let me know if there's any pain.
No.
Compared to this side?
None.
Very good. So now to palpate for the spleen, we're going to do the same technique by lifting up from the back and take deep breaths. Take another deep breath. And we can percuss again. Next, we can also palpate our kidneys, and I'm going to palpate with inspiration. So take a deep breath in. Take another deep breath in, out, and hold. Again. Again. So the kidneys and the spleen were not palpable and hepatomegaly not noted. We can also palpate our aorta. Moving on to our peripheral vascular examination. In this portion, I'm going to combine our upper and lower extremities. So starting off with inspection, we can see that the hands and the arms are both bilateral in size, symmetric, and they don't appear to have any swelling. There's no prominent veins seen either. So the skin is tan without bluish discoloration. There's no visible cyanosis or clubbing of the left or right fingernails, which is something that we have already established with our assessment of the skin. Now moving on and taking a look at the legs. The lower extremities are also symmetric without any signs of edema. So here the skin is tan, also without any discolorations, and there are no other abnormal findings of the nails of the feet as well. So for example, here we are looking for any duskiness or dusky red skin, which can be seen as a result of peripheral arterial disease. I can see that the hair is evenly distributed on both legs as well as in both arms, and no varicosities are seen, which can also be indicative of venous insufficiency. Other than that, there are no lesions, ulcerations, or pigmentation of the lower extremities, all of which could be suggestive of venous insufficiency. Looking back at our upper extremities and doing our peripheral vascular assessment, I want to start off by assessing our pulses and comparing them to the other side. Starting off with our radial pulse, and it's at an expected amplitude of 2+, and our brachial pulse. And also with an expected amplitude of 2+, and then we can compare to the other side. And all pulses are strong and at 2+ in amplitude. As part of our peripheral vascular assessment, I want to check for our capillary refill at this time. on each nail. Moving on to the left hand. Capillary refill is brisk and color returns in less than 3 seconds. Moving on to our lower extremities here, let's start off by palpating our femoral pulses. And we can always compare these bilaterally. And our popliteal behind the knee. Moving on to our dorsalis pedis pulses. And our posterior tibial pulses. And they all feel to be about 2+ in amplitude without any thrill. At this point, we can also check the capillary refill of our nails of the lower extremities. And the capillary refill also is less than 3 seconds for each nail. Lastly, once again, we can determine that there is no edema in the legs, and we can double check by compressing in different areas to check for peating edema. Taking a closer look of the lower extremities, here we can see the hip, knees, ankles, and feet. They appear symmetric without swelling, deformities, nodules, or bruising. Now we can palpate the knee specifically on either side of the patellar tendon. Tenderness of the knee.
No.
So tenderness near this area would be suggestive of a patellar tear. Now let's do our palpation of the ankle and the feet. Pain or tenderness?
No.
And then let's do the right. No pain?
No.
So we can see no bogginess, tenderness, or pain upon palpation of these areas. Now I'll be checking for the range of motion of the hips, knees, ankles, and feet. So starting off with the hips, I'm going to have you flex by bending at the knee and pulling up towards the chest. Great. Other foot. Very good. And extend. And for extension, we would reposition our patient prone and bend the knee upwards and lift upwards to check for that. For adduction, I want you to move the leg immediately over the opposite leg, so cross it over one another. Very good. Abduction, we're going to bring the leg out and the leg up. And lastly, for internal and external rotation, if we see that this range of motion is limited, then hip arthritis can be indicated. All right, so for knee flexion, I want you to bend your knee, which we can see that it is in that position. For extension, go ahead and straighten your legs. And then internal, external rotation, and then I will help you for internal and external rotation. Okay, so we can see that there is a full range of motion of the knees. And now for the ankles, go ahead, flex your foot upward. And this is to check for plantar flexion. Dorsiflexion, point your feet down. Inversion, in and eversion out. Perfect. After having checked our range of movement of our lower extremities, we can now test for the muscle strength. So for the hips, for flexion and extension, I'm going to ask you to raise your legs up against resistance and then push them down against resistance. Excellent. So now for abduction and adduction of the hips, I'm going to have you push out and then inward. Very good. Now for knee flexion and extension, I'm going to ask you to straighten the knee. And again on the left, right, and then now back down. Lastly, for the ankle strength, I'm going to ask you to push down like you're pressing the gas pedal, and then push upward. Very good. Excellent. So we can see that the muscle strength of the lower extremities is all 5 out of 5, which is active against full resistance. So now we can do our, again, neurological examination of our lower extremities, which is inclusive of our deep tendon reflexes. Excellent. So our deep tendon reflexes are all intact and expected. And lastly, to assess for gait, go ahead and take a few steps across the room. Excellent. So for this, we can see that the patient's gait is smooth with a continuous rhythm. So for coordination, which is part of a neurological assessment, we've already tested for the finger to nose testing, and for our lower extremities, go ahead and sit down, and I want you to run your heel down your chin, your heel down your shin. Very good. And we can see that it moves in a straight coordinated line, and we've already assessed the gait. An uncoordinated gait can be seen in patients with cerebral disease, and tandem walking may reveal distal leg weakness. So going back, I want you to now walk on your toes and then walk back on your heels. Excellent. Next, I want you to hop in place for about 5 seconds. Excellent. And now, again, as a part of our neurological assessment, we are checking the stance. We can do our pronator and Romberg exam. So for this, we have the patient standing with feet together, eyes closed, and go ahead and stay that way for a few seconds. And we can see that the patient is able to maintain an upright posture without sway. Now for our pronator drift, similar to this, but now I'm going to have you extend both arms out for about 30 seconds, out to your sides. Excellent. So we can see that there is minimal sway, indicating a good coordination for the patient. And sticking to our deep tendon reflexes, we can move back up to our upper extremities and check for our starting off with our biceps reflex and our triceps and our brachioradialis reflex. The same on the other side. So all deep tendon reflexes are intact and expected. And lastly, as a part of our neurological assessment, we will be checking for sensation to light touch and sharp touch. So for example, this is light touch and this would be sharp. So we can have the patient go ahead and close your eyes and let me know what sensation is felt.
Light. Light. Sharp. Sharp. Light.
And now moving down to the lower extremities, keeping your eyes closed.
Light. Light. Sharp. Sharp. Light.
Excellent. Next, with the patient supine, we can do our cutaneous stimulation reflex, and this again is part of a neurological examination. Starting off with the abdominal reflex, we can trace an X outward from the umbilicus, and there should be very slight contraction of the musculature here. And lastly, checking our plantar reflexes with the opposite end of our reflex hammer, we can stroke the lateral aspect of the foot from the heel to the ball of the foot. And we should see the flexion of the feet like that. Okay, very good. And with that, that concludes our examination.